By the end of this lecture, you will be able to answer all the questions, be it subjective or objective, under the topic of bronchogenic carcinoma. But then the first question itself is, what is bronchogenic carcinoma? Broncho refers to bronchi, bronchiole, and in this case, alveoli as well. Genic refers to generating from, and carcinoma is cancer arising from epithelium. So bronchogenic carcinoma refers to cancer generating from epithelium lining bronchi, bronchiole, and alveoli. Or in more simpler terms, bronchogenic carcinoma refer to cancers arising from bronchi, bronchiole, and alveoli. Or in even more simpler terms, bronchogenic carcinoma refer to lung cancer. But not just any lung cancer arising from respiratory epithelium present within the lung lining bronchi, bronchioles, and alveoli. Okay. Now, if you flip through the pages of Robbins, you'll find a table classifying various bronchogenic carcinoma, which you can mock up for theory exam purpose. But right now, we are going to learn about the 4 most clinically significant or the 4 most commonly prevalent bronchogenic carcinoma. They are squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and large cell carcinoma. All I want you to do is take out your note, be it your physical note or digital note, make a table and start filling that table along with me. I assure you, once you know how to fill this table now, there won't be any question, any concept left behind. All you have to do is fill this table along with me. So let's begin. First things first. So what are the 4 most common or 4 most clinically significant bronchogenic carcinoma that you need to know? Squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and large cell carcinoma. The most common bronchogenic carcinoma is adenocarcinoma, followed by squamous cell carcinoma, then small cell carcinoma, then large cell carcinoma, then the rest. But at least remember, the most common bronchogenic carcinoma or the most common lung cancer is adenocarcinoma of lung. Okay. Prognosis. Small cell carcinoma has the worst prognosis. It is the most fatal out of all. One of the reasons also being that it shows the highest level of metastasis. So it shows maximum metastasis. Affiliation with smoking. Squamous cell carcinoma and small cell carcinoma have strong affiliation with smoking, which you can remember as SSS. So S for smoking, S for squamous cell carcinoma, and S for small cell carcinoma. Gross feature. So grossly, lung cancers have broadly 2 types. First, the central or hilar type is found in squamous cell carcinoma. The central or hilar type is also found in small cell carcinoma. In the rest, that is in adenocarcinoma, you have peripheral type. In large cell carcinoma, also you have peripheral type. So the letter C kind of sounds like S. So central, squamous, small, or just simply remember CSS. So the central or hilar type is found in squamous cell carcinoma and small cell carcinoma. Remaining is adenocarcinoma and large cell carcinoma, where peripheral type is found. Now, what is the main gross difference between central or hilar type and peripheral type? Let's see. This is the central or hilar type and this is the peripheral type. The obvious difference is in their location. So the central type is towards the center of the lung, so-called central type. Or it's towards the hilum of the lung, so also called hilar type. So location. It arises from the central bronchi. Remember, the central type or the hilar type arises from the central bronchi. Right here, the central bronchi. The peripheral type, called so because it's towards the periphery of the lung, and it arises from peripheral bronchiole or alveoli. Second difference, cot section. When you take a cot section of the central type tumor or the cot section of the peripheral type tumor, this is the difference you see. In central or hilar type, it is yellow-white. The cot section is yellow-white. The peripheral type, it is gray mucoid. So let's take an example. Let's say I ask you the gross feature of adenocarcinoma. You know that adenocarcinoma has peripheral type of lung cancer. That means it arises from peripheral bronchiole or alveoli, and the cot section is gray mucoid. That's it. Another example. Let's say I ask you the gross feature of squamous cell carcinoma. You know that it is central or hilar type, so you can say that it arises from central bronchi plus the cot section is yellow-white. Another thing, the central type, as they grow, they can easily obstruct the airway, the bronchi, the primary bronchi, the secondary bronchi, leading to obstruction in airflow. Okay, next, precursor lesion before invasion. See, all these carcinoma, they are cancers, and cancers are invasive in nature. But before the formation of this invasive cancer, there was a pre-existing lesion. Before the existence of this invasive form, there was a pre-existing non-invasive form. See. So there was pre-existing lesion which was non-invasive. Okay, within lung there was pre-existing lesion which was non-invasive, and this pre-invasive lesion which was non-invasive eventually converted into carcinoma which is invasive. So now you need to know for individual carcinoma what are the pre-existing non-invasive lesions. Okay, for example, squamous cell carcinoma. Again, little bit of concept, use concept, no need to mug everything up. Squamous cell carcinoma has what type of gross feature? The central or hilar type. Central or hilar type. That means it arises from central bronchi. Bronchi is lined by columnar epithelium, but the tumor is squamous. That means the columnar epithelium lining the bronchi is replaced by squamous epithelium. This is referred to as squamous metaplasia. So that is the precursor lesion. First there is squamous metaplasia. Everywhere you can use concept squamous metaplasia, which is then followed by squamous dysplasia, which is then followed by squamous carcinoma in situ. Still not invasive because it is in situ. Then this squamous carcinoma in situ first shows little bit of invasion, micro invasion, and then full-blown invasion. That is squamous cell carcinoma. All right. Second, adenocarcinoma. It has two precursor lesions, AAH and AIS. AAH stands for atypical adenomatous hyperplasia. Again, atypical adenomatous hyperplasia. AIS stands for adenocarcinoma in situ. AAH is less than equals to 5 millimeter in size. AIS is less than 3 centimeter in size. AIS is also referred to as BAC or bronchoalveolar carcinoma. So adenocarcinoma in situ is also referred to as bronchoalveolar carcinoma. Once again, let's look at both the precursor lesions of adenocarcinoma, that is atypical adenomatous hyperplasia and adenocarcinoma in situ, with the help of two pictures, histology that has been given in Robbins. These two. So what did I say? There are two different precursor lesions that can eventually lead to adenocarcinoma of the lung. First is AAH, that is atypical adenomatous hyperplasia. Second is AIS, that is adenocarcinoma in situ. AAH is less than equals to 5 millimeter in size and AIS is less than 3 centimeter in size. Adenocarcinoma in situ is also referred to as BAC or bronchoalveolar carcinoma. Again, use another concept. See, adenocarcinoma, I said that what type of growth does it have? Peripheral. That means it arises from peripheral bronchial alveoli. Adenocarcinoma arises from peripheral alveoli. So if carcinoma is arising from alveoli, that means the precursor lesion has to be in alveoli as well. So that's exactly what's shown here. Bunch of alveoli has been shown here. Bunch of alveoli has been shown here. And this is the septa of the alveoli. This is the septa of the alveoli. The septa of the alveoli is lined by squamous epithelium to allow diffusion of gases. But in this case, since there is formation of precursor lesion, what happens? In atypical adenomatous hyperplasia, the septa is lined by cuboidal cells along with fibrosis. So there is cuboidal cell along with fibrosis. In case of adenocarcinoma in situ, the septa is lined by mucus-filled cells. It is lined by mucus-filled cells. See, if microscopically in adenocarcinoma in situ, there is mucus-filled cells, and this adenocarcinoma in situ eventually leads to adenocarcinoma, then grossly, if you cut that section, what appearance is it gonna give? It is gonna give mucoid appearance. Simple logic. That is why in cut section of gross of peripheral type, I said gray mucoid array. Microscopy, in a microscopy, there are mucus-filled cells. So in gross also, when you take a cut section of this, there is gonna be mucoid appearance because there is all that mucus there. Okay. Precursor. Third, small cell carcinoma. So according to Robbins, small cell carcinoma arises de novo from neuroendocrine cell. See, small cell carcinoma is a neuroendocrine tumor, and I've already taught neuroendocrine tumor in detail under carcinoids, under GIT pathology. And the advantage of knowing neuroendocrine tumor beforehand is that the basic features of neuroendocrine tumor or the basic characteristics of neuroendocrine tumor is same for all types of neuroendocrine tumor. That's the advantage. Okay. See, so small cell carcinoma is a neuroendocrine tumor. Neuroendocrine tumor is nothing but tumors that arise from neuroendocrine cell. So according to Robbins, small cell carcinoma is such a neuroendocrine tumor that has no precursor lesion, and it arises directly, all of a sudden, from neuroendocrine cells present in your respiratory epithelium, according to Robbins. But some studies, and even in Robbins under etiological factors, a precursor lesion for small cell carcinoma has been mentioned, and that is Dipneck. Dipneck. What is Dipneck? It is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. So before the formation of small cell carcinoma, there is a precursor lesion. That precursor lesion is hyperplasia of neuroendocrine cell. Obviously, because neuroendocrine cell tumor is small cell carcinoma, then first hyperplasia of neuroendocrine cell takes place, and then the neuroendocrine tumor, that is small cell carcinoma, forms. So there is hyperplasia of neuroendocrine cell that leads to small cell carcinoma. Where is hyperplasia taking? Within the lung. Because the neuroendocrine cell is within the lung, so pulmonary. The reason is not known, so idiopathic, and the hyperplasia is diffuse, so diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Again, there is hyperplasia of neuroendocrine cell within the lung or pulmonary, and the reason is not known, so idiopathic, and the hyperplasia is diffuse, so diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Large cell carcinoma, no precursor lesion. Okay, next, mutations. I can't be of much help for mutations. Now that you have to mug up on your own. There are lots of mutations given for each of the carcinoma, but at least remember the most important mutations. Squamous cell carcinoma, there is loss of 3p, 9p, and 17p, or there is TP53 and P53 mutation. For adenocarcinoma, the most common mutations are gain in function of EGFR, ALK, and KRAS. For small cell carcinoma, in almost all the cases of small cell carcinoma, there is loss of 3P. Okay. Next, immunohistochemistry or tumor marker. Squamous cell is P40 positive and P63 positive. Adenocarcinoma is thyroid transcription factor 1 positive and napsin A positive. Small cell carcinoma. Again, I said that small cell carcinoma is a neuroendocrine tumor, and it is a great advantage that you know neuroendocrine tumor beforehand. This is the reason why. Small cell carcinoma shows all the neuroendocrine tumor markers. So if you know what neuroendocrine tumor markers are, it is going to be positive for all of them, right? So what are the neuroendocrine tumor markers? There are 3 INS and 3 letters and numbers. What are the 3 INS? Synaptophysin, chromogranin, and bombesin. 3 letters and number: NSE, CD56, CD57. Again, total 6 neuroendocrine tumor markers that are positive for all neuroendocrine tumors, be it small cell carcinoma of lung, be it carcinoid of the lung. It's the same for all neuroendocrine tumors. The 6 neuroendocrine tumor markers, they are 3 INS: synaptophysin, chromogranin, and bombesin, and 3 numbers and letters: NSE, CD56, and CD57. Good. Large cell carcinoma. It shows a diagnosis of exclusion. What does that mean? It means that you diagnose a patient with large cell carcinoma when all other possibilities are excluded out. That is, if there is no squamous cell carcinoma, there is no adenocarcinoma, there is no small cell carcinoma, then most probably it is large cell carcinoma. So diagnosis of exclusion, that is diagnosed when all other possibilities are excluded out. Paraneoplastic syndrome. Squamous cell tumor, it produces parathormone, which leads to hypercalcemia. Adenocarcinoma tumor secretes procoagulants, which leads to Trousseau phenomenon, which is seen in migratory phlebitis. The reason I have broken the whole terminology is to explain that itis means inflammation. Phleb comes from phlebo, meaning vein. Thrombo refers to thrombus. And migratory refers to traveling. So in migratory thrombophlebitis, there is inflammation of vein along with the formation of traveling thrombus within the vein. And this phenomenon of frequent formation of thrombus in different sides of the body in vein is referred to as Trousseau phenomenon. Why is it taking place? Adenocarcinoma tumor of the lung is continuously producing procoagulant. Procoagulant factors, they promote coagulation, promote the formation of thrombus. That is why at different sites within your body, within your vein, there is formation of thrombus. And this is referred to as Trousseau phenomenon, which is associated with migratory thrombophlebitis, where there is inflammation of the vein along with the formation of traveling thrombus within the vein. Small cell carcinoma. It produces ACTH and ADH. Too much ACTH leads to Cushing's syndrome. Too much ADH leads to SIADH. Simple. SIADH means it's a syndrome of inappropriate secretion of ADH. SIADH, syndrome of inappropriate secretion of ADH. There is, after all, inappropriate secretion of ADH due to the formation of the tumor. The tumor is secreting ADH. It's not physiological ADH. It's being secreted by the tumor. Small cell carcinoma can also lead to Lambert-Eaton syndrome. Okay. Large cell carcinoma. It produces estrogen/progesterone, which can lead to gynecomastia in male. Gynecomastia in male. Okay. Next. Okay, finally, really important. Something as a pathologist or a student learning pathology you must know, and that is the histopathology. What is there? Squamous cell carcinoma, adenocarcinoma, small cell carcinoma, large cell carcinoma. First, squamous cell carcinoma. In squamous cell carcinoma, microscopically, you get to see two things. Number one, keratinization, that is deposition of keratin. If the deposition of keratin takes place within the tumor cell, which is intracellular keratinization, and outside the tumor cell in the matrix, that is extracellular keratinization. Due to deposition of keratin within the tumor cells became eosinophilic. So eosinophilic tumor cells. Eosinophilic tumor cells. So for each histopathology, I am using two diagrams. Number one, this is from Horseman and this is from Robbins. So the Robin is obviously the accurate representation, what you see under the microscope. And Horseman is the one that you can draw in your exam. So see in the Robbins histology, okay, there are these cells that appear bright red in color. Why? Because they are highly eosinophilic. They are eosinophilic because there is deposition of keratin in them. So these are the tumor cells inside of which keratin deposition has taken place. Second, due to extracellular deposition, there is whirling of the tumor cells leading to formation of keratin balls. Keratin balls. See here, there is whirling of the tumor cells leading to formation of keratin balls. See here, whirling of the tumor cells, whirling of the eosinophilic tumor cells leading to formation of keratin balls. Second, there is also presence of intercellular breezes. So in exam, when you draw, this is what you need to draw. First, draw the tumor cell. Draw them highly bright pink because they are eosinophilic due to the deposition of keratin in them. And then draw intercellular breezes in between them. Make some of the tumor cell in whirling pattern, that is due to keratinization outside the cell in the matrix, forming keratin pulse. That's it. Second, adenocarcinoma. Now, adenocarcinoma is found in various patterns like acinar, which is glandular pattern. Solid, that is the tumor cells are arranged in sheets, plain sheets. Papillary, that is the tumor cells that are arranged in finger-like projection. And micropapillary, that is the tumor cells are arranged in pseudopapilla. Pseudopapilla. What's the difference between papilla and pseudopapilla, or what's the difference between papillary arrangement of tumor cell and micropapillary arrangement tumor cell? In a papillary arrangement, the tumor cells are arranged in finger-like projection along with a fibrovascular core. In a micropapillary arrangement, the tumor cell is arranged in finger-like projection, but there is no fibrovascular core. Good. Another very important pattern is a lipidic pattern. I'll explain what lipidic pattern is. Wait. So what is this? This is the microscopy of immunohistochemistry. And all these darkly stained cells that you see right here, they are the tumor cells. And the reason these tumor cells are darkly stained is because of the presence of tumor marker in them. In adenocarcinoma, what is the tumor marker? I taught you two, thyroid transcription factor 1 and napsin A. In this immunohistochemistry, we are looking at darkly stained tumor cells due to the presence of thyroid transcription factor 1. Okay. Lipidic pattern. Okay. See, very first I taught you that adenocarcinoma is which type? It is a peripheral type. That means it arises from peripheral alveoli. So the tumor is arising from alveoli. So the lipidic pattern is obviously gonna be in alveoli as well. Your alveoli is normally lined by squamous epithelium. However, in adenocarcinoma, that squamous epithelium is replaced by cuboidal to columnar epithelium, and this is referred to as Clara cells. What are Clara cells? These are cuboidal to columnar cells lining alveoli that produce mucin. So these Clara cells, they produce mucin. Do you remember something? In the precursor or the pre-existing lesion of adenocarcinoma, that is adenocarcinoma in situ, I said that the alveoli is lined by mucus-filled cells. These are not Clara cells. These are the mucus-filled cells in adenocarcinoma in situ. When this adenocarcinoma in situ eventually develops into adenocarcinoma with lipidic pattern, then the alveoli is lined by Clara cells. These Clara cells are cuboidal to columnar and they produce mucin. Okay. Then small cell carcinoma. Again, the advantage of knowing neuroendocrine tumor beforehand. I've already taught you neuroendocrine tumor under carcinoid of GIT pathology. So the microscopy or the histopathologic features are gonna be the same for almost all neuroendocrine tumors. So in neuroendocrine tumor, what do you get to see are small, round, blue cells with indistinct border. See, the cells are small, they are round, and they are blue, and the border is not distinct. So these are actually the nucleus of the cell. The outer border, it is not visible. So the reason the cells are small, round, and blue is due to the presence of large blue nucleus, with less or scanty, barely there is any cytoplasm, scanty cytoplasm. Plus there are areas of necrosis as well. This is important as well. There is necrosis. Okay. Now, this is from Robbins. This is from Horsmohan. This is from Robbins. This is from Horsmohan. Just so you know the source of the images. All right. If I zoom into individual tumor cell, you can see that there is granular pattern that is present. Individual tumor cell, there is granular pattern that is present. What type of granular pattern? So there is dark granule and there is white granule. Dark granule, white granule, dark granule, white granule. It seems as if there is pepper on top of salt, giving salt and pepper appearance. That is due to the presence of fragmented chromatin material giving that dark fragmented appearance on top of white background. So this gives salt and pepper appearance of cell. Previously, small cell carcinoma was also referred to as oatmeal carcinoma. The reason being, the tumor looks as if there are looks like a oatmeal. That is, you take a bowl of milk and then put oat on top of it. So that's the appearance it is giving off. Okay, oatmeal appearance. Another thing, what do you see right here is the wall of a blood vessel, and the wall of the blood vessel appears really blue or basophilic. Why? This is the reason why. I said that the necrosis part is important, right? This is why. Due to the necrosis of the tumor cells, the DNA from inside the new tumor cells leaks out. And these DNA, they stick on blood vessel wall. As a result, the blood vessel wall, it appears blue or basophilic. This effect is referred to as azopardy effect, very important, azo-party effect. So few important terminologies. Number one, salt and pepper appearance of individual tumor cell. Number two, oatmeal carcinoma referring to small cell carcinoma. Number three, azo-party effect. What is azo-party effect? Due to necrosis of these tumor cells, the DNA from inside the tumor cell, it leaks out. This leaked DNA goes and sticks on the wall of the blood vessel. As a result, the wall of the blood vessel appears blue or becomes basophilic. This is azo-party effect. Large cell carcinoma, it is quite the opposite of small cell carcinoma. So here you have large tumor cells with distinct border and distinct nucleoli. Sometimes giant cells might even be visible. Giant cells, depending on the type of large cell carcinoma. Other than that, large cell carcinoma is not that important. So now you know the microscopic features of all four carcinoma. One last revision. Squamous cell carcinoma, there is keratinization. Inside the cell, intracellular keratinization leading to highly eosinophilic tumor cell. Outside cell, extracellular keratinization leading to the formation of keratin pulse. Plus, in between tumor cells, there are presence of intercellular bridges as well. Adenocarcinoma present in various pattern like acinar referring to glandular pattern, solid referring to tumor cells arranged in sheet, papillary referring to tumor cells arranged in finger-like projection, micropapillary referring to tumor cells arranged in pseudopapilla. The difference between papillary and micropapillary or papilla and pseudopapilla is that in papillary there is fibrovascular core in between the papilla. In pseudopapillary or micropapilla there is no fibrovascular core within the papilla. Then there is the lipidic pattern. In lipidic pattern, the alveoli is lined by Clara cells. Clara cells are cuboidal to columnar cells lining the alveoli that produce mucin. Small cell carcinoma, it's the same as neuroendocrine carcinoma, where you see small round blue cells with scanty cytoplasm, indistinct border and large nucleus. Plus there is necrosis as well. Due to necrosis, the DNA from inside the cell leaks out. The DNA from inside the tumor cell leaks out. It goes and sticks on the wall of the blood vessel, making it basophilic. This is referred to as azo-party effect. If you look at individual tumor cell, it gives salt and pepper appearance. The carcinoma, the small cell carcinoma, was previously also referred to as oatmeal carcinoma. Then large cell carcinoma, there are large cell with distinct border, distinct nucleoli, and sometimes giant cells may also be visible. Okay. Finally, metastasis. In Robbins, it has been written that in more than 50% of the cases, or almost 50% of the cases, long tumor metastasizes for some reason to adrenal gland, where the adrenal gland. Then following that is liver, brain, bone. But then in 50% of the cases, long tumor metastasizes to adrenal gland.